Welcome to the Dogtor Bros, where we have an honest discussion around vet life in and out of the clinic. My name is Chris, and I'm your doc of the day and your guide to this episode. I'm a GP in Winston-Salem, North Carolina, and I'm here with my closest friends.
Hey, this is Brandon. I'm a small animal internal medicine associate veterinarian in Colorado.
Hey, this is Jeff. I'm a veterinary dermatologist in Louisville, Kentucky.
And hey, this is Adam. I'm a relief veterinarian in Louisville, Kentucky.
And this is Chris again. And in today's topic, we're going to be talking about common vet specialties and providing some insights on them and what we learned about them along the way from our veterinary experiences and expertise. So this is more just our opinions about these different specialties. But before we get into that, we're going to do our opening game, and we're going to do another Would You Rather. And so started off is, would you rather manage Cushing's disease or diabetes?
This is Jeff. I'm thankful for my mentors. It's going to be Cushing's every time. I won't manage a diabetes, actually. I'm calling Brandon immediately. So every now and then I will catch a Cushing's one. I guess it depends on if our Cushing's episode has come out before or after this one, but you'll find out that I do treat a little bit of Cushing's. So I'll take that any day of the week.
This is Adam. This is kind of a tough one for me because I actually don't mind managing either of these. We had a really good discussion on Cushing's disease, and I do a fair amount of diabetics as well. I was actually texting you guys a few weeks ago I had like 6 newly diagnosed diabetics over the course of like 2 weeks. It was a very odd time, but yeah, I honestly, I'd take on either of these.
This is Brandon. I deal with these fairly frequently, and they're both annoying to manage just at the end of the day. But I think I'd go with Cushing's primarily because, for the most part, unless they have an adrenal tumor, the risk of dying from just not treating the Cushing's is significantly lower than if you don't treat diabetes. So just for kind of long-term outcome, owner compliance, risk of adverse effects, I'd rather, manage a Cushing's patient that is just peeing more than animal with diabetes that is dying.
Yeah.
Good answer.
Good answer.
And this is Chris. I'm in the same boat as I think everybody is. I want Cushing's. I rather deal with Cushing's than diabetes. Or Adam said he doesn't care. Yeah, I like Cushing's better than diabetes. And then one more question before we get into this episode is, would you rather have to amputate a forelimb or a hind limb?
What?
If you had to do the surgery, which one would you rather do?
This is Brandon. I would just go with hind limb just because it's a hind limb and they're going to be able to walk a little bit better than if you took a forelimb anyway, generally speaking.
Yeah.
That's all I've got.
This is Jeff. Hind limb because I did it with you, Chris, in vet school to Adam's dog. If you don't know what we're talking about, go listen to one of those first episodes from season 1.
This is Adam. I will also take hind limb because back when I did do surgery, way back in the day, the one amputation I did was a hind limb surgery or a hind limb amputation. So maybe a little past experience would come into play. So I guess I would take hind limb.
And this is Chris. Yeah, I'm going to go with hind limb. But I mean, forelimbs are fine, but I think hind limbs, as Brandon alluded to, I think they walk better using if it was a hind limb amputation. All right, so back to talking about different vet specialties. So we're going to start off with our 2 kind of softball specialties with internal medicine and dermatology. So let's start off with dermatology. Let's get into it. Like, what do we, difficulties wise, kind of length of residency? Give us some information about it.
Yeah, I mean, the the joys of dermatology, I'll say, I feel like it's a very approachable specialty because it is one of the reasons I got into it is because every year I think there is market research showing that it's one of the most common reasons people take their pets to the vet, and there's only around 400 dermatologists. So I think it's like we see skin every day. It's really common. I find it to be very approachable, but I also meet vets who are like, this is so intimidating because there's so much that can go wrong, or there's so many different tests you can do, and because a lot of things look exactly the same. I think that's probably a difficulty of my specialty. But I do think, kind of like, if you are a general practitioner or if you've been to vet school, like, you've had to deal with some skin and some skin disease. And so I liked just getting into the nitty gritty things of like the advanced procedures, so biopsies and the ins and outs of immunotherapy and allergy testing and skin testing is very, very fun to me, and I find fascinating. I think people struggle because the difficulty comes in the patients as well, not the actual animals, but like having to wait to see things get better. You have to have the heart of somebody who can sit and wait to treat an infection for 3 to 4 weeks, or wait to put pemphigus into remission for 2 to 3 months. You just have to sit on your haunches and trust. It's a very trust the process specialty, I think. Our residencies are usually 3 years. Quite a long time ago, they were 2 years, but our boards, it is an 8-hour boards test with credentials that look like research papers, writing test questions, case report has to be done. It is a lot of work, but also we're rarely on call. And I think we also get the benefit of having long-term patients. So most of the things I do are not curable. So I get to see my patients more like I did in general practice. Like, even when you're doing well, I might push you out to a yearly visit to keep refilling meds like your immunotherapy. So those are things I really, really like. And brief anecdote, I'll also say I really like teaching when I'm speaking, because I think I've gotten really good feedback about like telling general practitioners, and like, here's some tips and tricks that you can use right away in your clinic, because I can't see every patient. So those are things that I really like, because if I can teach other people to really improve their practice, they're going to help more pets. And then you're going to feel like you're doing a better job. And then things will get referred when I'll see even more rare things, which is what I love.
Yeah, no, that's all. I mean, it sounds like, I know we're kind of going into like trying to figure out if it's difficulty of specialty and things like that. To me, a lot of it too is more of being on call. So there's no on call for dermatology. I think that's a big plus, which goes into our next specialty we have on here, internal medicine. I know he was on call all the time during his residency. Brandon, you want to go into internal medicine?
Yeah, I'll just throw out a caveat, just like the dermatology specialties through the American College of Veterinary Dermatology, our kind of college or governing body, so to speak, is the American College of Veterinary Internal Medicine. And there are subspecialties within that, including mine, which is just small animal internal medicine, which is more general. There's also a large animal internal medicine. And then you have some things that are a little bit more niche, like cardiology, neurology, oncology. And then more recently, nutrition was added to our group, which is very fitting. So for my subspecialty within the American College of Veterinary Internal Medicine, it is kind of like the jack of all trades, so to speak, of like more advanced medical therapy. Like, I don't do really, the only surgery that I ever do is E-tube placement for a patient that needs an esophageal feeding tube. That's kind of the extent of my surgical skills. But other than that, we're doing kind of anything and everything you can think of internally that is not covered by the other subspecialties like cardio, neuro, oncology. So there's no veterinary like hepatologist. There's no veterinary gastroenterologist. Maybe those things will exist in the future, but right now that falls in the internal medicine category. Same thing goes for, generally speaking, the endocrine diseases that we manage, and a wide variety of other things. So the tricky thing for me in my specialty is that we just like derm, we see a lot of chronic patients. Unfortunately, a lot of those chronic diseases can be like have a high morbidity. So those patients tend to be very sick. And then we're just trying to manage that illness for as long as possible before it ultimately catches up to the patient. So things like more advanced kidney disease, things like potential liver failure if a patient's in liver failure, and we're trying to manage them for as long as we can for whatever caused that. And then there's, the flip side of that, where there's very simple diseases that maybe are just hard to diagnose, like Addison's disease. You get the diagnosis, treatment is very straightforward, and those patients can live a great long-term quality of life. And there's things in the middle, like chronic gastrointestinal disease, which can be managed with relatively low morbidity if you get it under control. But I've been in situations where patients will suddenly become very, very ill, and unfortunately, I have to say goodbye to a lot of patients more often than I'd like. But it is nice to have those long-term relationships. It is always interesting because there's always something different that I'm seeing. So I feel like I never get bored when it comes to different things. And we're kind of the catch-all, just generally speaking, if you're in a hospital that refers patients and hospitalizes patients and no one's really sure what's going on. If it's something more critical, it's going to get dumped on the critical care service, which we can talk about critical care in a little bit as a specialty. And then if it's something more stable that is just kind of generally unknown, it kind of gets shuffled over to internal medicine to figure out what's happening, which is in itself kind of fun, depending on the situation. So that is my specialty, so to speak. I will hopefully be labeled as a specialist soon once I finally get credentials submitted. Everything's ready. It just needs to get submitted, essentially. Cardiology, as most people know, is focused on cardiac disease. They do need to have a general understanding of internal medicine, so cardiology, neurology, oncology, and I believe now nutrition all have to take the same general boards-ish that I have to take, at least one of the tests. There's like two different categories. There's like a general boards that everyone takes, and then there's a specialty-specific general boards that are all kind of like lumped into just general boards in our second year of residency in our 3-year residency programs. And then the third year, we take specialty boards, which is very much focused on your individual specialty. I cannot speak as much for large animal internal medicine, but I know that they take a general boards as well as a specialty boards. So yeah, I don't know if you guys had any other questions about things with that group of specialties.
Well, one thing, this is Jeff, one thing I wanted to bring up, and then I'll ask a question. Like, I think I just completely missed the whole point of like, well, what do dermatologists even do? Because people do ask us, like, we deal with lots of allergies, genetic conditions. We're the ear specialists because there's a running joke in dermatology that's like, well, internal medicine wouldn't take it, so we just did it. And I think that's hilarious. I was like, oh, nobody laughed. So okay, I was like, I thought it was funny.
Yeah.
I don't know.
I don't do it, cheers. That's okay.
Audience, Brandon, straight face. I deal with autoimmune diseases, a little bit of skin neoplasia, every now and then a chronic wound, and almost no euthanasia, which is a big benefit for us. But I wanted to ask kind of to the group, like, what is y'all's, especially Chris and Adam, like, what are y'all's impressions of our specialties being on the front lines of most medicine? Like, how do you, like, what do you think about dermatologists and internists, just in general?
Yeah, this is Adam. So I would say in general practice, dermatology and internal medicine are the two specialties I refer to the most. With dermatology, just looking from an outsider's perspective, couple of pros and cons that stand out. Obviously, I'm happy where I'm at. I'm not looking to specialize, but just my general opinion based on what I see from the outside and what I see from JT. With dermatology, you do get to kind of build a little bit of a client relationship, and you're seeing those clients reoccurring, at least in the short term, until you get them stabilized and then sent back over to the GP, which is nice. I think it's nice that you do have kind of the steady, stable hours. I think you do have a tough job. I think you brought up a really good point that a lot of what you see looks similar. So you're kind of distinguishing between different diseases and different conditions that really present to you very similar. So you have to do some deep diving to kind of figure out specifically what you're dealing with. So a lot of pros and cons on that side. With internal med, back when I, for like a blink of an eye, thought that I might want to specialize, internal med was what I kind of thought about. A lot of pros and cons there as well. I think you bring up some really interesting points that, people may not think about, Brandon. You're definitely the catch-all. You're kind of like jack of all trades and the master of all trades at the same time. Because again, there's just a broad array of things. It's like, well, we don't know what's going on. We don't know what to do. Just send it to internal med. And kind of make it their problem. So there's a lot that comes with that. And, that's a tough job. I mean, that's tough. And then the biggest thing that you said that really stood out to me that I didn't think of, I mean, you're dealing with a lot of conditions that are, chronic, and then also, can be serious and can be life-threatening. And there probably is a lot of death and euthanasias and that side of the job that comes with internal med that we don't really think about as well. And again, you're kind of developing those client relationships as well and kind of working through those cases long-term as well. So, again, very interesting perspectives from both of you. Some things that I didn't really think about with both, but yeah, you two, both your departments, that's definitely who I'm reaching out to the most. So it's good to get kind of the insider's perspective on both of those.
This is Chris. Kind of perspective on both of your guys' fields is we just need more of you guys because we would have so many cases to refer. But yeah, no, like Adam said, you're probably the two most that we refer to the most. The only reason why I don't refer to dermatology more is because we don't have one really in our area. So hence why we need more of them. But shameless plug for JT to move out here. But
on the way. I'm
not. But anyways, yeah, I mean, I refer to internal medicine, I feel like, all the time. And then I'm also asking Brandon a bunch of questions to see how we can figure it out faster too. So it's definitely good knowing both of you, because now I can actually help patients a little bit faster sometimes because we can get something going, especially in our area where we have 2 internal medicine specialists for the entire triad, which is not enough for our area. No dermatologist, don't have a cardiologist. We have 1 neurologist for the area, 1 oncologist, no nutritionist. So for internal medicine, they kind of just do everything at that point besides the one that has neurology there. So again, it's underutilized. We just kind of utilize them so much for everything. So, and I know we're kind of alluding to next is emergency and critical care. They'd probably be the next one we do the most, but I don't think there's a whole lot of critical lists that I know about. I feel like a lot of them are at big hospitals or in big cities. They're not in our area. Brandon probably knows more about that than I do. And even you, JT, because you guys both did internships. But what is your guys' experiences with emergency and critical care?
So my experience, a lot of it was at my rotating internship. I specifically chose a place that had a huge variety of specialties, including it was really interesting because we had like our internal medicine department, and then we had, I think, 3 criticalists, but one of them was a criticalist double boarded in internal medicine. And I remember asking that doctor, because they Chris, I know. I can't stop laughing because it's so intense. And she did have to take both sets of boards. And from what I remember, they no longer have, correct me if I'm wrong, Brandon, like they don't have those 4-year I believe she took a 4-year program that was like a 4-year residency covering medicine and critical care. And then this doctor, she was one of my mentors. Like, she took one specialty first, and then the next one, I think, a year after. And I remember she was like, well, the studying was okay because there was so much overlap that it wasn't starting fresh. That's why it worked. And then they stopped doing those. I know at least that program, I think maybe all of them, but I know that program stopped because of the intensity. And I remember even asking, I was like, so what's the benefit of you doing both? And it was kind of like well, that particular doctor was like, I mostly do the internal medicine side with some sprinkling of the critical care. And that's what they leaned on versus like the ER side of ECC or emergency critical care. So like, I feel like there's a huge amount of overlap. And the last thing I'll comment is with ER, ECC critical care, unfortunately, that's the only specialty that I've had a specialist tell me maybe just do ER rather than doing the whole residency. So I'm interested if any of y'all have ever heard anybody say that. A dermatologist would never. We tend to love our jobs, and we need more of us. But I think there's some huge challenges, and the on-call and everything just makes it really hard. And there may not necessarily, depending on where you live, be an enormous difference in pay from a regular ER doctor versus the specialist. It just kind of depends. And I think that's where that comment came from, which kind of made me sad.
This is Brandon. There's a lot of overlap with ECC, or for emergency and critical care. I'll refer to ECC from moving forward, and internal medicine, specifically small animal internal medicine, a subspecialty. It's I worked very closely with our criticalists at Iowa State. We had a really strong critical care program. We had multiple residents, multiple criticalists, and we worked very closely with them. Depending on where you're trained, actually, I found this interesting after I kind of like got towards my end and out of residency. There's some residency programs where the internal medicine doctors and residents don't really even manage the hospitalized patients. It's all done through critical care. And then there's some like me where I was trained like, no, you're going to manage your own hospitalized patients, which I think was a big benefit just for my learning. Like, generally speaking, I like outpatient care and workups more so than my hospitalized patients, just as a stress thing on me. But some people really love that. We would call it in human medicine, I guess the equivalent would be like a hospitalist role, rather than like true emergency and critical care. So the ECC folks, like, they do both ER as well as like more of like the ICU type patients. So patients that are on like potentially a ventilator or just require very intensive round the clock care. And we leaned heavily on them, and they leaned on us too. I mean, they don't want to be managing something long-term. They're more of like, this is just to make sure that the patient gets through this terrible period. And they have a lot of knowledge, in particular when it comes to like fluids, electrolytes, and those kinds of different things. Then obviously they're going to be doing more surgical type interventions on patients as well. Not as much as like a true surgeon, but more surgery, generally speaking. So they're a very well-rounded, also kind of jack of all trades-ish specialty. And I think they're very important. Someone had mentioned, like, or I think it was Chris mentioned, like seeing them only in like specific specialty hospitals. It's kind of weird. They don't have a great role as like at a small hospital. They're really designed to be at these hospitals that do a lot of like major hospitalized patient management. So I know surgeons will rely on them very heavily with certain post-op cases and stuff like that. And they just play a really integral role for like a larger veterinary hospital.
And this is Chris. Yeah, that makes sense, Brandon. And I know JT was saying he's heard ECC doctors say, hey, I wouldn't go into this to be an emergency doctor. And I've actually heard that as well, is that you don't need it to be an emergency doctor. But if you're doing what Brandon's saying, is you're working at a giant hospital group and you're managing all these cases, then yeah, that makes sense. But at that point, you're more of a hospitalist, kind of managing everything and making sure everything's working right. So yeah, again, it's sad to see that some people say you don't need to do a certain thing in the specialty, but it's needed. I guess it's more of a niche that you need it for. But if you want to just be an ER doctor, you don't need to be a criticalist or an ECC to do everything.
Yeah, like for like one example would be something that people don't do very often, but is an option for some hospitals is dialysis. Like a lot of patients that require dialysis, whether it be something more acute, like a toxic injury, or a patient with like really severe leptospirosis that they just need to treat it and get them through that period and salvage the kidneys. Those are the doctors that are doing that nowadays. You're not going to be able to find another doctor out there right now, at least like an ER doctor, any other subspecialty that is doing stuff like that. I'm sure that there are maybe a handful of internal medicine doctors out there that have that special interest and are like doing that training and have that capability. But for the most part, it's critical care doctors, the ECC board certified doctors.
I can only imagine how much that costs to do dialysis.
Oh yeah.
A lot.
Yeah, that's is that or a new car, like whatever you will prefer.
Thousands. You are talking about thousands with something like that.
Yeah.
But there's a market for it. Like I've had clients that just, they have either insurance or they just have that, they have the financial capability to do that. And if it's indicated for a patient, like I would love to recommend it and send them to the right place. We have a hospital just maybe 45 minutes from where I work that does it. And I haven't had a case yet, but I know where to send them if I do.
No, that's awesome. Because I know for our area, like people have asked us about it. So I'm like, I don't even know anyone even remotely close that can even do dialysis. And it's, again, I know it's cost wise. I don't even know unless you have insurance if it makes sense for them to be able to do it or not. So, yeah, no, it's definitely a good thing to know, but I think it's something that's going to happen more commonly in the future. But so kind of going into these next few ones, again, we don't have as much experience with them because, again, we're not we're not boarded in these specialties, but we have talking about surgeons. We got some small and large animal, pathology and radiology. We can kind of go through these pretty quickly, but what are you guys' kind of experiences with dealing with surgeons, pathologists, and radiologists and how they deal with clients and kind of just difficulty level wise and everything?
This is Adam. I'll hop in real quick from the GP side, just my experience with these. Surgeons, obviously anything that's out of the wheelhouse of our in-house surgeon, I do recommend to a specialist. There are some surgeries that are out of the realm of our surgeon that other GPs are willing to do. Some of the same things Chris is doing, luxating patellas or...
Couldn't even remember what those are called. Yeah.
Lateral sutures, fracture repairs, those sorts of things. I got there. Things that Chris is willing to do. There are some GPs in our area that are willing to do those things as well. Obviously, I referred to the specialist first, but I do offer those GPs as kind of a cheaper option. Surgeons in our area, they do great work. Obviously, there's some that are just, beyond any GP when we're talking about like IVDD or intervertebral disc disease. They need back surgery. That's a specialist. So there is a time and a place where it's like, that's your option is the specialist. From the perspective of me, my perception of their kind of life in the clinic, that's something you gotta love, right? I mean, you gotta love surgery to go and get specialized in it. And I think anybody that goes down that road, like that's what they want to do is surgery. And more power to them because we need them. For sure. Pathologists, I use these a lot, when just sending in samples of like an FNA in-house or histopathology from mass removal, things like that. And we get a lot of really good information from them. And have a pretty good relationship with them. They always leave their contact information. If I have any follow-up questions, I'm more than willing to reach out, and they're always willing to help with my comprehension or next steps or whatever it may be associated with their report. Personally, I think that's a very obviously important specialty. And I feel like that's a pretty good specialty as well. I mean, you don't have a lot of face-to-face contact, obviously, with owners. Your quote-unquote clients are really general practitioners or maybe even other specialists. But again, they play a very important role. And I feel like biggest thing for me when I think of specialty and importance is work-life balance, because I know those can be pretty demanding. I feel like pathologists have a pretty good work-life balance just from my personal perception of them. So I think that's a really big plus of them. But again, something you got to love going into that. And then lastly, radiology. I'm trying to wrap up quick so everybody else can go. With radiology, biggest thing with that I see is sending in radiographs or even ultrasounds. Again, get those reports, which are typically fairly helpful. Radiology is another one that I always thought seemed interesting, just because, again, I feel like there's a lot of flexibility with radiology, and it kind of depends on where you're at and what your position is and where you're working. But I feel like there's a lot of flexibility with that in terms of when you work, where you work, that sort of thing. So I was kind of always drawn to that as well, in the realm of just thinking of if I specialized, what I would specialize in. So I've always been interested in the flexibility of radiology as well.
This is Jeff. I'll say, okay, so surgery, pathology, radiology, right? So surgeons, probably the hardest hands-on specialty, I would say. And they also have those long hours, on-call hours is pretty common. In derm world, we use them a lot for when I send a patient who's got like mineralized ears that I cannot do medical management on. I'm going to send them to a surgeon for a full ear canal removal or a tikaboo most of the time. Sometimes we'll cross over paths for chronic wounds. They may ask us for advice. We may ask them for advice for things that are just like chronic and need some help, because we'll manage them in different ways. And masses that are larger than, like, for the most part, an 8mm punch biopsy is almost the biggest that I will go. But I've also whipped out our laser and taken off a few masses a little bit bigger than that before. And then like anal sac removal, I usually will send them. Honestly, I've heard it's not that difficult, but I'll send them to a surgeon or back to a general practitioner who really enjoys surgery. And I'll also put in a quick anecdote. Like, one interesting thing about dermatology is that there are some really skilled surgeons that are not boarded, but like dermatologists really, really skilled with lasers that will cut like partial podoplasties, all the material in between the toes. And every now and then you'll get somebody who'll do an ear and different things. And everybody that I know who have done these types of things have worked under surgeons and really closely with them. So it's interesting. If you have interest in surgery and you want to go into derm, you can still make a niche for yourself there. With pathology, I mostly lean on the anatomic pathologists who read my biopsies. And for the most part, I'm sending them to a dermatopathologist, which is not a subspecialty yet itself. Like, it's not its own specialty that you can get boarded in, but there are about 3 double boarded pathologists and dermatopathologists. One is one of my resident mates, and she's really, really good. And I always send my biopsies somewhere that is someone who always does, or like has really special interest in derm and pathology, or is double boarded. And then with radiology, I'll say Brandon just put nerds in our group chat. I mean, you got to be pretty good if you're going to get double boarded. I'm going to just say that. With radiology and diagnostic imaging, most of my experience with them in derm world is sending things for a CT scan or an MRI as planning before like a video otoscopy when I'm going to go and flush out an ear under anesthesia and flush out the ear canals. And for planning to see, like, maybe is there a mass in one ear or the other? That's really, really helpful to me. But I actually work-life balance, pathology and radiologists, and your local dermatologists are probably pretty high up there. We usually keep pretty normal work hours.
This is Brandon. Yeah, just to like kind of go off of your work-life balance comment, I think on the opposite end of the spectrum, I think surgeons would have the least work-life balance, and that's like the close competitor there would be crit care, and then shortly after that would be my group in internal medicine. But the surgeons and the surgeons definitely have it the worst. I think critical care, depending on like the scenario, they also have it pretty bad when it comes to quality of life. So if anyone's ever interested in doing those specialties, like just be aware that the training in itself is a juggernaut. And I'd put my group in that category as well. It was very hard. But as my mentor used to say, if it wasn't hard, then everyone would do it. That's what he would say. When it comes to these last three groups, just as other asides, like surgery, very difficult, very time consuming, very competitive. A lot of people want to be surgeons and boarded surgeons. Probably one of the more high paying specialties. I think critical care would probably go up there as well. Surgery is just, it's its own beast. So like everyone else has kind of alluded to, you need to be really passionate about that and really dedicated. Maybe just be single to do that.
That's funny.
No family, have no pets. I've worked closely. Fortunately, I've worked with like almost every specialty that we've talked about so far directly. And surgeons we work with very closely in internal medicine. If we find a mass, if we find something that needs to be cut, if we find something that's like really difficult that needs a biopsy, we are reliant on our surgeons. And I work with my surgeons closely today. Pathology, one thing I actually miss, believe it or not, I miss something about residency. When I was in residency, we could just go and talk to the pathologist directly and they'd show us the slides and we'd look at everything, and having that relationship was really nice. So that was more so with the clinical pathologists. With my specialty, that's what we use them more for. But we also do submit biopsies for things like gut biopsies or liver biopsies and stuff. And we need an anatomic pathologist to make a report for that. But I agree with everyone's previous comments on that specialty. And I think they're integral to what we do, just not just derm, not just medicine, but for GPs as well, submitting like fine needle aspirates of masses. And then, radiology is a really big one. I think everyone here uses a radiologist, probably, if not daily, at least once a week.
Not everybody here.
I
probably refer to a radiologist like, I mean, as far as people who actually go, like, it's not that many.
Okay, fair enough.
I very rarely talk to a radiologist.
Okay, no, I don't think about that much. I would like, but I guess thinking about it, there's nothing you need to X-ray of the skin, so makes sense.
Yeah,
but I think as far as radiology is concerned, though, it's very important. I miss having a radiologist to talk with directly about things like a CT scan or an MRI, and they're going to be reading out those as well as ultrasounds and radiographs. They're also going to be doing more difficult aspirates of things with ultrasound guidance, with CT guidance. They're going to be the ones that are involved in some clinics in doing the radioactive iodine for thyroid, like hyperthyroidism in cats. Internal medicine does that as well. You just need the specific licensing and everything to do that. So I think that they're really important. If something happened to me and I was all of a sudden single and had to like do a residency all over again, I'd probably pick radiology.
Me too.
Yeah, I'm into ultrasound now. I'm doing ultrasound as an internist, but I would be really interested in doing the rest of that specialty as well. Maybe we'll be able to get a radiologist or some of these other specialists on at some point and talk to them directly about their experiences.
You could always get double boarded.
That's if I wanted to be divorced or maybe die.
Hey, you could always get boarded.
Well, Yeah. Oh yeah. Really quick caveat on that.
No, reverse.
when you bring up people that are double boarded, why? What are you doing?
Oh my gosh, it's crazy. Some people do it. There's so much more overlap than I thought of going into derm with pathology.
Yeah.
That it's really, really interesting. I did let a slipping thought in my brain think, like, what if I went and did a fellowship? And I was like, no.
I thought about that stuff too. It comes into my head and I'm like, oh wait, I don't want to be miserable again.
Yeah.
Yeah.
Those are all good points. I mean, again, wrapping up real quick on everything. Surgeons refer to them a lot. I do a lot of surgery in GP, but we know what we can and can't do, and we send a lot to the surgeons. And yeah, they're definitely good to have. We wish we had more in the area. Pathologists, we use them all the time, especially when we send out any mass removals, things for path reports. To see them, they don't really interact with our clients. It's more just with us talking to them. And then staying with radiology. I mean, we have radiologists that will do some reports and talk with the clients, but overall, it's just talking to them. But unlike JT, I used a radiologist on Friday. This past week, we're recording this on Sunday because I had to get a second opinion on some x-rays for a dog. So use radiology a lot. So they're great. And I agree with Brandon again, from difficulty wise or life balance wise, surgeons seem like they have it the worst, which is one of the reasons why I didn't want to pursue it, because of a work-life balance. I saw that as a hindrance for me and my family. And as you guys know, I had a kid in vet school, and I just couldn't imagine going through a residency, especially that residency, or trying to accomplish that if I could get into it and everything. So, and then pathology seems like they have it pretty good with a good work-life balance there, and staying with radiology. But yeah, so that kind of wraps up today's episode on the specialties. I know we didn't mention all the specialties. We can expand on this. I mean, this could be like a 5-hour episode on all the different specialties. If you just Google the AVMA specialties in veterinary medicine, we were shocked by how many there were. Like, I don't even think we realized how many specialties there are in vet medicine until we actually pulled up the list. So we kind of just made it smaller on things that we deal with most often, but there are a ton of specialties out there. So if we didn't mention your specialty, it wasn't on purpose. It was more just for time's sake.
Yeah, and if we didn't mention your specialty, or we did, and you want to come talk to us, please reach out on our social media, which you'll hear in just a minute.
No, for sure. And then to wrap up this episode, we're going to do one of our outro questions. And it is, what kind of music do you guys enjoy, or what are you guys listening to now?
This is Jeff. I'll say the most common thing I listen to is going to be like a lot of pop music, a lot of rap music, and a pretty heavy amount of reggaeton because of my Spanish. So lots and lots of that.
This is Adam. I listen to a little bit of everything. I'm kind of open to a lot of different types of music. I kind of like music in general. Rap, pop, rock, country, you name it. I probably listen to it. So yeah, a little bit of everything, really.
Yeah, this is Brandon. I'm like Adam. I listen to a little bit of everything. I'd probably lean more country music than anything else. But I'm down for pop. I'm down for rap. I'm down for reggaeton, especially. Love the beat. And not as much into rock or alternative. But I think what I found myself doing, and I'm interested to see what you guys say here too. I'll just throw on like a 2010s playlist, like hits, and just like let it go.
Yeah.
For sure.
And it's a little bit of everything, and it's fantastic.
Yeah, no, that's good. And I'm like Adam and Brent. I kind of listen to a little bit of everything, except I don't listen to a lot of country. I've been listening maybe a little bit more, but even then, I wouldn't consider it country. It's like Zach Brown Band, which is more just like beach country or ocean country.
Ocean
I was
country?
gonna say
Yeah.
I was gonna say Post Malone and Beyonce. I don't know if that counts.
Yeah,
I mean, Beyonce
technically
did
they-
win Album of the Year with a country album.
Technically, they have country albums, but
yeah,
You don't have to like it, but she did win.
yeah,
They're
yeah.
good.
So that kind of country.
good.
They're good.
Yeah, that's it. But I do like reggaeton too, as you guys. I will also listen to that, and I do like rock a lot more, which I guess is different from everyone else. But rap.
Cause tonight is the night where I will fall for you over again.
nailed it.
You're welcome.
I loved that.
Thank you once again for joining us on the Dogtor Bros.
If you would like to support us, please share this episode with others who may be interested in today's topic, and leave us a 5-star review on Apple Podcasts, Spotify, or wherever you listen to your podcasts.
Would you like to influence our next episode? We love hearing your opinions and thoughts. Your comments may be our next topic.
Please leave us suggestions via email at thedoctorbros@gmail.com, DM us at thedoctorbros on Instagram, or leave us comments on our posts. Again, this is Brandon. You can reach me at Dr. Mason IM on Instagram.
And this is Chris, and you can reach me on Instagram at dr.chrishernandez.
And this is Jeff. You can find me on TikTok or Instagram at DermDrJeff, DermDogtorJeff.
And this is Adam. You can reach me on Instagram at Dr. Adam DVM. That's DRADAMDVM.